This podcast is sponsored by Path to Publishing, helping authors to take control over their publishing journey for over 21 years. Visit pathtopublishing.com to get on the path to publishing your next book.
Welcome, everyone, to It's Truly Novel, the podcast where we are exploring all things new on the internet. I have with me Dr. Savanna. Thank you so much for joining me, Dr. Savanna. And he's going to talk to us about a new approach to medicine where he takes the money out of the equation. So, Dr. Savanna, thank you for joining us. Tell us a little bit about what happened to make you decide to take this new journey.
Thank you for having me on. So, as I have mentioned to you before, my first love has been medicine. And of course, I wanted to come to US to further my studies and do what I am supposed to do and I'm good at doing. So while going through that, I've noticed the changes over the years, that slowly but steadily, the patient has become secondary. It's become a number. And the only way I thought was probably to be happy and do your best with nobody telling you what to do is to take the money out of the equation. But of course, you'll not be in a position to do that. Your bills don't know that. And your tuition fees don't know that. And your loans don't know that. So I started working on it for very early, and I took those things out of the equation. But over the period, I've noticed that I was becoming more and more frustrated, giving myself a headache, sleepless nights, and feeling very unhappy with myself. So the first chance I got, I said, thank you very much, and I got out of the system. And I took the money out so I can do what is best, and then the payment becomes secondary.
Nice. So how is that? I mean, how is it that you decoupled from the system? Because I mean, it's a pretty complicated thing to do. You know, you're right. Your bills don't know that you don't. your landlord doesn't stop asking for payments, or your mortgage broker doesn't stop asking for payments. The student loan association doesn't stop asking for payments. So how has that worked out for you?
So I worked for it. So when I was working for it also, I was trying to be in the middle, trying to do what is right, to get the payment too. And the more and more it was going towards the right payment and system and protocols were given, and you get punished for not doing the protocol, forgetting the basic fact that protocols are general guidelines, especially from the physician world. For us, where independent and critical thinking was instilled in us in our education throughout the year. And now you are trying to tell me that fit the diagnosis into either like one of the category, like small, medium, large, and just go follow what is told to you. And that doesn't fit well with any physicians. I don't think you see many physicians very happy other than doing procedures. And when they look at the bank account, that's about it probably, but they're not happy. That's the same reason why I said, let's take it out and see. So the time I was immediately ready, I set up my office, small one, just like a traditional one. I own everything, so there's no bills waiting. Then
Nice.
I got him.
Nice.
So I waited entirely 1.5 years to see whether my theory is right or not, because I think patients are also frustrated with this, being treated like a number, not spending enough time, not explaining what is going on with them and what is the approach. So not a single ad, not on social media, not on the paper print, word of mouth as patients came. So this has been 1.5 years, maybe 18 months, 19 months. Today we have 1,400 patients.
Wow, 1,400 patients.
Mm-hmm.
That is impressive.
So when I just started with myself and somebody in the front office doing all the work, and slowly we started putting in the systems in. Now I have 5 employees and another physician who's retired, but still comes and does his own patients like 6 hours a day for three days a week, and 8 hours at the office when I'm not doing it. And pretty much we see 25 to 30 patients every day.
And how are you feeling? I mean, a year and a
Oh,
half into
happy.
this.
Happy.
Yeah.
My wife feels like this is the least amount of money you made in the last 1 year in my entire career, but this is the happiest I've seen.
Wow. Yeah. So how often is it that you struggle to make ends meet? I mean, is it a common occurrence, or is it just,
It took a year. Let me put it this way. The whole year, I did not take any single dollar from the practice, because the thing is, we are trying to make sure that the bills of the office, what we generate, are paid. My employees are paid. And I think I pay for the same kind of the job, the top dollar in the town, because I strongly believe that more than half of our conscious time we spend in the office, and that should not be a stressful place. You should feel happy to come to work.
I agree with that assessment.
One of us, we know the other one's inside out. If anything is bothering, we easily pick it up. Let it be me, let it be anybody. Walk by, say, what's going on today? You don't see me yourself. Simply like that. And first of all, made sure that their payments are all there. And I had to put in money in the beginning of the year, which kind of sort of explains why no new physicians want to start their own office anymore, is because you have to put in the money, plus you take in far less than any one of the corporations offer you right from the beginning without any responsibility.
Mm. Yeah.
And pretty much a doctor's job in the corporate world of the hospital has basically become a shift system. Clock in, clock out, there's nothing else after that.
Yeah. Yeah. I've worked a little bit in the medical profession as a nurse aide, and I saw a whole lot of that kind of mentality, and it bothered me, which is why I didn't stay in the medical profession. I didn't like the way the system treated patients, and I didn't like the way it treated the people that worked for it. Everybody was like a cog in a machine.
Yeah, so if you think about it, the whole medical profession is nothing but a service industry, right? You service the patient and the patient needs. But I think, as far as I can think, this is the only service industry where the provider has no say. Because you see a patient, you have no control whether you're going to get paid or not, if the bill is going to get rejected or not, and how much you're going to get paid, how much you're going to write off. You can't dictate what you want to charge. You have a plumber call in, you can take the quotations, and you can go with the least or the highest, or somewhere in between, depending upon what he offers, but not in this field, right? You might write a medication, but that is not be authorized by the insurance company and say, oh, our preference is something different, right? The same thing with any test. And hospitalization, you think the patient needs hospitalization, somebody else decides, oh, it's not needed. And half the payments will come back, half won't come back. But at any one point, including the non-compliance of the patient, it's your responsibility.
Yeah. Yeah. There's a lot of responsibility that's put on the medical profession.
So in this day and age, and that's where the liability insurances are high. And at any given time, according to the payments right now, for every dollar you make, if your overhead is already decided 60 cents, and you have to put that upfront if you're going to open your office and wait for the payment.
Wow.
So no wonder the no new ones want to come in here at all.
Yeah. I can imagine that it would create significant financial challenges. So.
And imagine that coming up with an average debt of $250,000 in the United States right now. who would want to do that?
Have to be a special level of crazy, right?
Yep. So I think that I am one of the lucky few ones, and crazy ones probably wanted to try this. Is thanks to this country that working for 20 years made me what possible where I am right now. Then I had to make a choice.
Yeah.
Either you want to do your passion, what you want to do, where even there is no money, or if you want the money, you can open a gas station.
Well, that's true.
And luckily, working 20 years, I have enough money to start a gas station, and I definitely know I can make more money than here.
Well, that's probably true. That's probably true. You know, so what are some of the surprising things that you found now that you took money out of the equation and you decided to put the patient first? What are some of the surprises that have come along the way?
The surprising thing first for me is I thought even the patients have changed. They've got used to the factory kind of a thing. What are you doing for yourself? The patient never questions, what am I doing to correct myself? Looks for an easy answer, happy pill for everything, and somebody else's problem. So maybe I thought, oh, when they come to see the doctor, they basically, this fast generation wanted the treatment yesterday and a relief yesterday. So when I started, I had thought maybe that's what's I'm going to see. They see, like, same thing. People are going to walk in with, oh, I have sore throat today. I have this headache today. So some medication, some antibiotic. Is that all? I thought maybe that's how it's like an urgent care.
Mhm.
But what surprised me was people are fed up of what is going on right now. So when you sit down and explain this is what's going on, it's the same patients. They're actually coming back to say, okay, this is my doctor, this is my office. Before I go anywhere, I'm coming here.
Mhm.
And after a year and a half, at least 20% of my appointment where the patient takes an appointment and comes in is to discuss what the specialist has said, that we are going to do this or we might need this, is here to discuss that with me, should he do it or not.
Well, I think that when you take the money out of the equation, there becomes a level of trust that the doctor is there for you, not for the paycheck,
That's
and
correct.
and it shifts the conversation between the patient and the doctor. They know that your advice is not based on whether it's going to profit you or not, but on whether or not it's actually going to be something that's good for them.
Yeah, that was definitely surprising. I thought only older people are going to go this way and the younger ones are going to come in for some acute visits, but it was not the thing. But when we talk about it and say, hey, for example, take a simple back pain. Most of the times I get to ask the patient, the next step, according to the book, what we have to do is an MRI. Now, I don't think it's the disc, but if we find a disc, are you willing for the surgery? The patient said, no, I'm not going to go for surgery at all for this. What are the alternatives? So we discuss the alternatives and we don't even do the test, because what am I going to do with the test when the patient is not willing for the next step?
Yeah. I think that if you educate people, sometimes you can eliminate procedures before you even get them done, because the patient's not going to follow through with that course of action.
That's
So it
correct.
actually ends up saving you money in the long run, and them too. Because you're just interested in what their desired outcome is.
That's correct. So I asked them, if you're not going to go through surgery, what's the point for me to do a test and put you all through this to know what it is, which we already know the possibility. And I did not think that the younger generation would not want that. They want more done. But when you explain and, oh, that makes sense, let's not do it. We'll
Yeah.
wait and see how it goes, and then we're going to come back. At the same time, if you express a doubt and say that, hey, I don't like the look of it, let's get a biopsy just to See, and if it's nothing, great. If it is something, then we can take action immediately. So then we're not going to kick ourselves for waiting for 6 months. They'll
Right.
say yes and go right away.
Yeah. Well, I think, like I said, once you've earned their trust, then it becomes less difficult to convince them to do the things that they need to do to take care of themselves.
Yes. So, and also I think from both ends, the trust is very important, because one major factor in this profession is you have to be convinced that you did your best, because sometimes you'll have to look into a patient's eye and tell them, this is it, there's nothing else. That means you're ending this chapter. And that takes a lot of confidence to tell that. And you have convinced yourself that, yes, truly, I looked at all the options.
Yeah, and you have to be able to sleep with that decision at night.
That's correct. Oh, I made the decision a long time ago. Long time ago, when I was studying for my last exam, I suddenly realized that I finished the last exam and I get my license to kill medicine, right? So with my carelessness or my bad day, if I don't pay attention, I might actually take a choice which might affect a patient's life. And if that person is the breadwinner of the family, I just killed a family. So I looked at it and said, medicine is all about choice. Do this or do that, or choose this or choose that. When it is choice, it's a matter of time. You flip a coin and you say heads and it's going to be tails. How are you going to live with that?
Yeah.
So I made my life very easy at that point. I thought about it. Who is the best person I love? My mother. So when I'm telling you advice, looking at the data I have, I don't see my patient there. I actually see my mother there. And I tell myself, if it's my mother there, knowing what I know and the data I'm looking at, what would I let anybody do to her? That is the advice I give it to you.
Wow, that is awesome. That is an awesome attitude to take. Because I think that it's very easy to depersonalize a patient and to forget that they are human beings with families and people who love them. And the decision that you make about what to tell them or what to prescribe to them can have devastating consequences, not just for them, but for the people that love them.
That's correct.
Yeah. So that is awesome. I love that approach.
So since then, I never questioned my judgment. If I told something, that's the best I could do at that time. So even if the outcome is bad, I can live with that, because I definitely know I did my best at that point.
Right. And the rest is you just got to leave that up to.
That's correct. Call it fate, call it God, and what's your karma. That's basically where it is. But I did my best there. And I'm never afraid to say, let's get help.
That's another good thing. I've met a lot of doctors who are afraid to admit that they don't know or that they're not sure. And I've always said that I would rather hear from a doctor, you know what, these are the facts that I know, but I don't know what may be the outcome. So let's go research or
check out somebody who's got more experience in this field.
Yeah, exactly.
Because I think people who have called all our seniors before and the generations before, there is a reason why they call a doctor's work a practice and not a job, is because you're learning through the last day.
Yeah.
There are always curveballs. That's why it's called a practice. It's not called a job.
Right. And there's always more to learn about the human body.
I truly believe if somebody says, I know everything, I truly believe that you just met a person to run away from.
Yes, I would agree with you. I mean, there are things we're discovering about the brain right now, the things we didn't know, that they used to think it was all carved in stone, that if your brain had a problem, there was no recovering from it. And now we know that the brain can actually be induced to grow new neurons, and many things can be fixed and solved if you know the right things to do that we thought were not healable or curable. So it's an amazing thing as we learn more and more about the body. So I guess that's something to discuss too. I understand from Wilnona that you have a kind of a different approach. A lot of doctors treat the body as individual pieces in
That's
a
correct. That's
machine.
another problem with the system. We have been, this is my personal opinion is, what we did is basing on the payment system, we have compartmentalized every part of medicine. So you go to a cardiologist and basically he's looking at the heart through a microscope and has 10 different things going on with the heart. And probably you might be right, you might not be right. So that's what has become to medicine. You go to a hospital with complaining of chest pain. What happens? Some chest is by definition anywhere between under the neck and up to the pelvis. So, oh, it's in the middle area. So let's make sure that it's not the heart. Heart comes back and says heart is normal. Oh, let's call the GI and get a scope done because stomach is in the same area. Make sure it's not the acid. Oh, then call the lung doctor and see. Well, you didn't go to medical school for that. You look at the risk, you look at the other things and say, hey, this is the heart, let's get the heart. So the classical teaching always has been, before you order the test, you should have a vague idea of what you're looking for. Not get the test and see the abnormalities and treat the abnormalities, which you see happening. Patient goes for urinary tract infection, something they're doing for because of the abdominal pain, they did the CAT scan and say, hey, this spot on here, we are going to go for biopsy. But what about my UTI? Oh, that can wait. We can do the biopsy first.
Yeah, not realizing that the UTA may be a sign of something bigger going on.
That's correct. So you see that happen. Now that you brought it up, I have to tell you, there is a joke or something I read in one of the lighter sides of life, basically, is there's this one guy who has this constant headaches. He goes to different doctors, do a lot of things. So somebody said you might have a brain tumor, he went to the neurosurgeon. He did all the scans, he did the EEG, everything, seizures, nothing is there. So he says it's not your brain, you're fine. Patient still has constant headaches. Then he goes to the heart doctor. Somebody said maybe it's your heart's not pumping enough blood to go to the brain circulation and all. So he went and tried the medications, but the doctor said nothing happened. Then he went to the lung doctor. They sort of told his problems. They've looked at the lungs and said it could be your lungs are not supplying enough oxygen, and that's why you're getting a headache. Maybe you have sleep apnea. Did all the tests, put him on some medication. Still, the patient has the headaches. So ultimately, he finds a doctor. He says, a urologist says, you know what? You have this particular condition. Basically, your testes are being pressed down to the lower spine, and that puts pressure on the headaches. The good news is I can treat this. But the bad news is I have to take both your testes out. And the patient's life is so miserable at this point. He says, okay, let me do this. And he goes through the surgery, both his testes taken out. Lo and behold, the headache is completely gone. When he comes out of anesthesia, there's no headache. He's happy. For the first time after a few years, he has not had the headaches. So he's coming, he's discharged and he's going back home. He's now contemplating, how am I going to go home and tell my wife what I had to do for this issue? And he was feeling depressed and down. He said, oh, my wife, whenever she feels depressed and down, she does some shopping. Let me buy in some new clothes. Maybe I'll feel good. He goes into a cloth storeroom. Basically, he looks at the mannequin and says, I like this color combination. So the guy looks into it and says, you're 34, 32 pant size. And the patient says, oh, how did you know it? Sir, it's my job. I'm the salesman. Let's try it on, and brings it 34, 32 and fits perfectly. He said, let's go for the shirt. Your collar size 15 and a half. He gets that right, sets it right. And he says, let's go for the hat. You're 9 and a half, and he gives him that, puts in, fits perfectly. Same thing with the shoes. It says, now what the heck, I bought everything. Let me buy all the underwear and every new undergarments. I wear 36. Can you get me 36? Says that will be too big, sir. I think you should wear a 30. You should wear a 34. He says, why? I always in my life, I always wore only 32. And the salesman looks at it and says, no, your size is 34. You should go for 34 or 36. He says, no, I've always wore 30, 32, and that's my size. So the salesman looks at him and says, sir, if you wear 32, your balls will be pressed to the spine, and that would cause pressure to the hip. That is what has become to medical science. Right now, we go specialty driven. Basically, everybody looks at their own thing. And in a situation like that, when procedures make money, that's where it is pushed.
Mhm.
In simple terms, I diagnose, let's say a patient has some bleeding. It takes me 90 minutes for the consultation, go through it, and oh, he's got bleeding here. It could be a tumor. He needs a colonoscopy. I get paid $90, and a 9-minute colonoscopy gets $900.
Oh my goodness.
That's
And
where
it
we
could
are.
be something as simple as wearing underwear that's too tight.
That's correct. You'll
Yeah.
not know until you step up. Because a wise professor once told me, medicine is only 1/3 knowledge.
Mhm.
1/3 knowledge, 1/3 common sense, 1/3 logic. The
Mhm.
difference between a good doctor and a not so good doctor is the one who knows to put three together.
Mm. I could see that. I could definitely see that. And I think sometimes we too narrowly focus on, if you all you know to use is a hammer, then everything looks like a nail, right?
That's correct.
So sometimes we're over eager to use modern medical treatment when it may not be necessary
That's
or
correct.
even productive. Yeah.
So the best example I can tell you in that is overusage. There was a point in time like 5-6 years ago, even they stopped saying that don't do PSAs after 70, prostate specific antigen for prostate cancer. You know why?
No.
Because the treatment has become so aggressive. More people were dying from the treatment rather than the cancer itself.
Oh my goodness.
And who do you blame? If nobody questions me why I have done something, rather than wait and watch, right?
Mhm.
Because you wait and watch, 99 go well, and the one who goes into the cancer, one lawsuit is enough to ruin my life.
Mhm.
And then the payer is going to ask, why didn't you do this? Because this is the protocol.
Mm.
But why didn't you ask that in the 99 where you didn't have to spend the money?
Yeah.
Right?
Wow.
And then doing more gets me more money. So instead of looking for the reason why not to do an invasive testing, which is the traditional teaching, you just look for a reason to do it.
Mm.
You do the test, you get paid, and say, oh, this is not my system. And then you washed your hands off. It's somebody else's problem.
That's a really important thing to know. It's like, oh my goodness. When the treatment is worse, well, that goes back to a lot of medicines. You sit there and you watch the commercial, and then they list the side effects, and you're like, okay, so it cures nasal drip, but it may cause external bleeding and, and heart problems and death. And I'm like, I'll take the nasal drip. Thank you.
Uh-huh.
Nasal drip better than death. So I think sometimes we tend to over medicate too. It's like
Oh,
too quick
absolutely.
to pass out a pill.
That's correct.
I'm a big believer in less is more when it comes to pills.
And we expect an 80-year-old, which you're also having a question of dementia, to take 16 pills at different times with you looking at the interactions 1-to-1, pretty much almost that gives you one pill at a different hour every time. So your life is rotating either taking the medication or going to the pharmacy or seeing a specialist or getting a test done. So you take any 80, 85-year-old logbook every day, day planner and take a look. At least more than 50% of them have got at least 2 visits in a week, working week, either for a test or seeing a specialist or getting blood drawn or going to the pharmacy to pick up the medication.
Mm.
And you expect this person to take 16 medications. Practicality, if you ever have to take a 10-day course of antibiotic 4 times a day, by the end of the 10th day, there'll be 3 or 4 pills in the box, and you'll be wondering, where did I miss the 4 pills?
It's
And you
true.
expect an 80-year-old to do that in 16 pills?
Yeah, especially when you already know they've got dementia. And I wonder how many of those pills are contributing to the dementia they're experiencing. You know, like how much of that
how
is
many of the
medical?
side effects we are treating with another medication?
Exactly. Because I know my grandmother had a, box full, like she had a little pill cabinet, and I'm pretty sure all of those things probably interacted with one another in not really good ways to create some of the problems she was experiencing.
So I have to tell you the interactions when the computer systems came in, right? When you put in any medication, automatically the system checks in for interactions, even the smallest minor ones. So they pop up. So the major ones, interactions, all the physicians are supposed to know, and we know, most of us know. So basically we avoid those. And when we put in the orders, anything, just put in a Tylenol in any hospitalized patient, there will be a warning popping up saying that, oh, there is a interaction between Tylenol and the laxative the patient takes. So you ignore that because it's a minor one and do it. So we looked into the hospital when I was working in the hospital as a hospitalist. In 1 year, there were approximately 400,000 orders put in. Okay. In that, how many times do you think the system prompted saying that there is interaction? Is probably 399,000 times. And how many times do you think the doctor overruled that? Probably 399,000 times.
Yeah.
So if you think about it, so you got so used to overriding it that it's only a matter of time when a major one will be missed.
True. Well, and even if it's a little interaction, those can add up.
That's correct.
Those little interactions may not be a big deal by themselves when they're isolated. But when you've got 5 or 6 of them, you can start causing some major havoc.
That's correct. We do see a lot of that too.
Yeah. Well, and of course, my grandmother was good about doctor hopping. She would go to various doctors to make sure that they didn't know which one was prescribing what.
That's correct. Yeah. So you come across that end of the stick too. So somebody believes that there's something wrong and there is something out there for me to get it, looking for it, and in the process ends up in so many different ways of different medications and everything. Because no doctor who starts, like for example, even if I see a patient, and when I ask the previous medications, I write down the list. And when you look at it, no doctor dares to actually get in and say, hey, why are you taking this medication? How long has it been taking? Why, under what circumstances was this started? And dare to take it away. Because again, as I said, 99% of the time I might be right. Nothing happens. That 1% happens, well, this is it. If somebody started this for a very reason and you have taken it out, maybe that's where the outcome, and you're fried.
Yeah. And it only takes that once, right?
Yep, it only takes once.
Yeah. And then there's the medications that are new on the market And they can be prescribed as the greatest thing since sliced bread and end up causing bigger problems than they were prescribed to fix.
That's correct.
My grandfather had that happen. He had problems with his kidneys. They prescribed a medication that was supposed to help. It actually ended up shutting them down. He ended up on dialysis. So, it was, but it was a new medication they thought was going to work. And turns out not so much. So I think we need to be maybe more cautious about the medicines we prescribe.
And the studies too. And the
Mhm.
studies too has to take their own time and biased and independent decisions. But as far as I hear, one of the books I read basically tells me, which is really surprising, is the FDA funding now actually more than 50% comes in from the private companies.
Yeah. Yeah.
So
From the fees
basically
that they charge.
So we are asking FDA, which is the watchdog, to bite the hand which feeds it. Not even
Yeah.
a dog is going to do that.
Yeah, exactly. Exactly.
No wonder there's so many recall on medications.
Yeah, I think that system is completely broken. And there's no third party oversight over the FDA. There's no citizens watch group. There's no medical watch group that is in charge of making sure the FDA stays on track. So it's kind of this thing where they can rubber stamp what they want to rubber stamp. And there's nobody to call them on it.
That's correct.
And I think that's probably an unhealthy situation for most people.
That's
it's going to end up, it's an inevitable consequence with things being done that shouldn't be done. It's kind of like, human beings are flawed. And if you don't have somebody watching to make sure that you're doing the right thing, even if you have the best intentions, you can end up making mistakes.
That's
letting things through that shouldn't be let through.
Yep.
So what would you like to see if you had a magic wand that you could wave and you could make anything happen in the medical profession? What would you do?
I think, as I said, if you really want to get back the medicine, the altruistic nature of taking care of patients, we have to take the money out of it. So if you take the money out of it, how are we going to do is basically you can make it difficult to get into medical school. We can give billions and billions of dollars away for any natural disaster, for any number of reasons. Why don't we make it the entry into medical school tougher, purely merit-based, and make it free once they get in? So there is no money.
Well, I know that there are programs where if a doctor goes through medical school, they can come out and they can get their loans forgiven if they're willing to work on like Indian reservations and in impoverished communities. I know that program already works and is in place, but often people aren't willing to move to those conditions. So it doesn't usually end up producing as many doctors as we would like it to.
So let me ask you this. Let's say you went to medical school and you have a $300,000 loan. They will tell you that basically, okay, we will forgive $50,000 loan per year, which probably your $300,000 have probably increased by its interest rate and everything to God knows how much number. $50,000 per year will be forgiven. This will be the salary given to you. You have to be in the middle of a small town and probably in New Mexico, someplace you're going to be in the middle of nowhere. Now, your family is in Maryland, Annapolis. Now you're 34, 35, having a life to start with. And you're committing yourself for almost 10 years down there to the loan forgiveness. Practically, where do you stand?
Yeah, exactly.
So, as I said, start cutting it off completely from the beginning is, okay, I don't have a big bill to pay to start with. So you pursue your passion, make it reasonable. And You go to buy a set of tires for your car. There are coupons. You can compare Walmart to Tire Rack to Target and go where you can go. Why can't we publish how much each hospital charges? What is the bill of this? How can this make right across the board?
Mm-hmm.
This is the price.
Yeah.
You choose where you want to go.
Yeah.
Then how can a system end up happy when, as a premium payer, insurance premium payer, you are unhappy that you're not getting the service which you think you deserve because you're paying a lot of money? And as a service provider, I'm unhappy because I'm not getting paid enough to get what I've provided for you.
Mm-hmm.
But the third party has $100 million bonus.
Yeah, I know, right? The insurance companies are making out like bank while the doctors and the patients are losing out.
So, and their answer for everything is this: oh, we could have done this. You have done a prior authorization. Come to my office and sit in. I actually have to have a person pay full 8-hour salary to go through the prior authorization system alone. And you want the physician to do it, you won't see more than 3 patients a whole day, where you have to see 12 patients to just meet your costs.
Wow. That's an interesting side of things. I know that the insurance companies were started with the idea that it was going to help patients make medical care affordable, but it's definitely not fulfilling its job, because you can have medical insurance and not be able to afford medical care. You know, if you can't afford the deductibles, or you can't afford the tests, or you can't afford this or that, your
So
insurance is no good.
there has to be a huge something wrong when you end up spending 15 to 18% of your entire GDP on healthcare system, and not to be on the top 10 of any one health condition
Mm-hmm.
in the world.
Mm-hmm.
We spend 3 times more than any of the other developed countries spend, but we are nowhere near.
Yeah, we've definitely got problems with our health system. It's not serving, I don't think it's really serving anybody except the insurance companies. It seems to be not serving the doctors. It's not serving the nurses. It's not serving the nurse aides. And it's definitely not serving the patients very well. And things have to change.
Somewhere. So that's what I'm saying. If you have to take the money out, you have to take a look at it and say, you know what? If you take the money burden out of the doctor, see, if I make $200,000 and I don't have any loan, you'd go anywhere, do anything, or move freely.
Mm-hmm.
If I know what the same procedure costs everywhere across the town, across the state, I will go where I feel is right,
Mm-hmm.
pay it there, get it done.
Mm-hmm.
It will
Yeah.
be the same thing. Your
Yeah.
choice is free, you can do free, and hold even the patient responsible sometimes. And
Yeah.
when the system says that if your health premium is decided on your cohort group of risks, if you
Mm-hmm.
belong to a 40-year-old man, so your risk factors of having heart attack are higher. If you're a woman about 30, pregnancy related are higher. So that's how the premium is decided upon your risks, right?
Mm-hmm.
So it doesn't matter, like you're 40, I'm 40, I smoke, my cholesterol is through the roof, but I like to eat pizza every day. Your copay and my copay is the same.
Mm-hmm.
Why don't we introduce a system that your copay is only $10 when you go, because you don't eat all the pizza, you don't get your cholesterol go out of hand, you don't smoke, and you exercise 30 minutes a day, and your BMI is within the normal limits of recommendation. Now, my copay, $50. Guess what? Immediate repercussion. My wife will stop cooking the pizza anymore because if my cholesterol comes down, my copay goes down to $20.
Mm.
If I quit smoking, it drops to 10,
Mm,
equivalent to you. That is responsibility on the patient side.
mhm. So it's a shared responsibility at that point. You know, the
That's
doctor
correct.
has their responsibility, but the patient also has their responsibility to take care of themselves and not to expect the doctor to do what for them, what they could do for themselves.
That's correct. And why should there be a difference in payment, what they pay a single physician who opens an office, whatever the insurance company offers, right? Take it or leave it, right?
Mhm.
And the same, from the same level of service, the payment would be different if you are in a big group and you have a common negotiator in between who has more number of people attached to them so that they can serve more populations or gives them more strength,
Mhm.
like a hospital system. So if all roads lead to Rome, so basically every road you will only be better served if you're attached to a corporation.
Well, I think one of the things that we could start doing is offering free housing to doctors who move to communities. You know, pick out one of the houses that we've got, we'll pay for it. You know, if they didn't have to worry about housing, that would be a huge help to them. If, you know, if they didn't have to worry about medical bills, you're right. The student loan fees for becoming a doctor are just exorbitant. And you add that on top of all the insurance that they're required to carry for liability. And it's a wonder we have anybody left in the medical profession.
I can think about 10 colleagues who basically were doing GYN and deliveries of babies, OBGYN.
Mhm.
Because of the liability, they actually stopped doing OB completely. And there are
Mhm.
states where so many people dropped out that pregnant women have to cross the borders to the next state to go and get a delivery done.
That's a serious problem when you've got that going on.
So the other part of it is this, maybe this is some of the price we pay for being a developed country and taking care of things better. Is because take any disease, early catch, early treatment. So actually the next generation of physicians will not know what will happen as the disease progresses,
Mhm.
right? So that means we might have to increase the teaching in medicine too. Again, brings back to the same point. 6 instead of 5 years, maybe they have to do 6 years. And if you take the money out, and we can send them to developing countries to do a year training there and come back for that particular diseases you're interested in, the specialties, we'll have better doctors.
Mhm. It's true. Well, have better doctors in the developing countries get the help they need. With, you know, I mean, if they
Mhm.
were put overseas for even a year or 2 years while they work on diseases that they wouldn't normally see in a developing country,
That's
stages
correct.
of progression, they'll
That's
get
correct.
experience that they need to know what to look for when they come back to the developed country. So it could be a win-win for both sides.
That's correct. And again, as I said, think about it at every stage. At some point, you have to take the money out.
At some point in time, you have to find a way to subtract the money from the equation to produce the kind of care that everybody needs. And to give the doctors the peace of mind. And I don't think most people get into the medical profession looking to make money. I think most of them get into it looking to help people.
Well, when I was teaching I've seen the transition from that to a little bit more while teaching. Going back about 20 years, 25 years ago,
Hmm.
if you interviewed all the people who got into medical school and said, what was the reason for getting in? I was interested, fascination, and just to help other people probably contributed to 90% of the answers. Right now, if you go to any medical school and ask the medical students what is the reason, is yeah, some of the answers might be this, but they'll clearly tell you, I want to become the specialist in so and so thing to do the so and so procedure. Why? Because people need it, I get paid, and I'm not responsible for anything else. Why does it have to come to, oh, your bone is broken, you're an orthopedician, can't you fix it? No, but I can send you to the specialist for the person who has actually practiced in hand and to fix the fracture in your pinky finger. How many people does it take to screw the bulb?
Good question, right? Well, that's an interesting thing, though, to note that shift has been from I want to help people to I want to get into this profession because I want to make money. And I guess that if you did take money out of the equation, then what you could do is, as part of the interview screening process for medical school, is why do you want to go to medical school? You know, what is your true motivation? And so those who aren't motivated by a desire to help people could kind of be screened out.
True that, but what happens is when they write the articles, actually that's how they do their interviews and their essays, portraying that. But the clarity in what they want to become is based on the payments of today or the future, what they're thinking about. Procedural oriented. So procedure oriented basically gives two things to the specialist. Number one, you basically do the procedure, so you say that there is no risk, and I've done the procedure to show that patient does not have a condition of my system, so I am off the hook. Right? If you think it is a liver problem, I did the biopsy, it's not the liver problem, but the pain is still there, doctor. It's not my problem. Go and talk to your primary and see what's the next system.
Okay. Well, this has been a fascinating interview. It's really great to get to know you, Dr. Savanna, and I love your perspective on medicine, and the thoughts on what we can do to maybe improve the system, maybe to make it a more effective thing for both doctors and their patients. So if somebody wanted to connect with you and maybe get some medical advice or maybe seek you as a physician, where would they need to go to do that?
My office is open right now. We are open 8:30 to 4:30 summer.
So you're in Annapolis, Maryland, is that correct?
That's correct, Annapolis, Maryland.
Yeah, and you do telemedicine too, though, don't you?
Yes, we do.
Okay, and do you have a website that they could go to?
Yes, it's under development. As I said, we are going to launch it probably this summer, because I wanted to see for 2 years, where is it going?
Nice.
So I have noticed that, as I said, as I wanted to do the medicine out of passion, there are patients who are looking for alternatives, which are looking for like the wholesome medicine, not cutting and just pointed medicine. Yeah, at times it is needed, but not understanding what is wrong and what we are trying to correct, and having patience and winning confidence of patient-doctor relationship, that values are still there out there. So both ends of the sticks are feeling shortchanged. Let me put it that way.
I agree. Yeah. So your website is coming. It's not up yet, but it is on the way. Correct?
That's correct.
Okay, well, we'll keep up to date. And as soon as you have that website, and you can send it over to me, and we'll make sure to put it on the It's Truly Novel website. So again, this has been Dr. Savanna and It's Truly Novel podcast, where we discuss all things new on the internet and around the world. Thank you for watching and have a great day.
Thank you very much.
Oh, thank you. It's been lovely. You have a wonderful day.
You too. Thank you very much.